Good afternoon, everyone. Welcome, and thank you for joining us today. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Centers team, otherwise known as MCTAC, and I'm happy to be joined by some of my state partners today from OASAS. Today, we're going to be covering the topic of OASAS's residential redesign, and our presenters on the webinar today are going to be Ileana Meltzer and Henry Kurtzman. Before I pass to both Ileana and Henry, I did want to just run through a few logistics for the webinar today. So we are recording this webinar, as you may have just heard, which is great because that means you can listen to this afterwards. We'll be posting this to the MCTAC website. So stay tuned. After we complete the webinar, we'll upload it to the MCTAC website shortly, along with the slides. The other thing I wanted to remind everyone of today is that we are going to have time for question and answer. We built that in to the webinar today. So we would encourage you to chat your questions in using the chat box functionality. If you look at the right-hand side of your screen, you'll see there's the chat box there. So we encourage you to chat your questions in that way. And there's no need to wait until the end of the webinar. Feel free to chat them in throughout the webinar as they pop up. But we'll be addressing them at the end of the webinar today. So with that, I'm going to thank everyone for joining us and ask Henry to start us off on the webinar.
Thanks, Meg. Good afternoon, everyone. Great to have you guys all come to this webinar today. So why are we here? Part of our webinar today will be a refresher on the underpinnings of 820, and some of the webinar will cover some of the lessons learned from our most successful early adopters of 820. Why residential redesign? Residential redesign has been a response to providers and participants' needs for enhanced staffing to meet the complex requirements of the SUD population we serve. So we heard very clearly that our intensive residential providers, our 816 providers, our halfway houses and supportive living providers that have been doing excellent work for years have always been understaffed. They didn't have the medical staff to meet the needs of the population. There were long waits to provide mental health services to those coming to us with co-occurring disorders. Part 820 also fills the ever-growing gap between detoxes and the community. People are being released into community with little or no support and are overdosing. So residential redesign through Part 820 expands our referral base as well as our funding streams to provide quality services to the population we serve, and those concepts will be further explored in the following slides. So our learning objectives this afternoon are to identify the strategies and culture change needed to implement residential redesign, define the underpinnings of Part 820 residential redesign, and really differentiate both the criteria and services within the elements of care in 820. Residential redesign transformation. Residential redesign offers us an opportunity to utilize the 1115 waiver, which became effective 10/1/2015, to successfully work with managed care plans to support the provision of SUD treatment services in OASAS-certified residential programs. The transformation of residential redesign services in New York State is multifaceted and designed to redefine and develop more responsive set of residential treatment services and greater accountability for outcomes. The model advancements in clinical quality offer access to MAT. It improves the quality of clinical and recovery wellness services. It increases access to medication-assisted treatment as the provision of these services are mandated in all elements of care. It also speaks to integrated care, integration of medical, mental health, and SUD services within residential facilities by, for the first time, enhancing the staffing to and creating transdisciplinary teams to address participant needs. It speaks to evidence-based programming. The model allows for enhanced staffing, as I just spoke of. There's care matching to reduce per capita costs. The focus on care matching to the levels of care as well as services that they require. It speaks to the use of locator to 3.0 to decrease emphasis on hospital detoxes and increase community-based options, and ultimately to reduce per capita costs. Key to the transformation is our partnership with managed care plans. The communication and collaboration with these managed care plans cannot be emphasized enough. It also speaks to advancing quality care. So some of the underpinnings of 820, when we say what are the foundational pieces of this transformation, has focused on person-centered, trauma-informed services. It utilizes locator. It matches people to the best level of care to meet their needs. It's participant-driven and not program-driven services. We've talked about individualized treatment and treatment plans for years, but we're not as participant-focused as we could be. It speaks to flexibility and the ability to address the person's need within time frames suitable to the person's ability and experience. So the focus for our providers previously has been fixed time frames for programming individuals, when the focus should actually be individual milestones that people achieve to move them through the different elements of care. It realizes the impact of trauma as an important component of effective behavioral health service delivery. Historically, our focus has not been on measurement-based care tools. The science for SUD has finally caught up. We've always talked about the art of counseling, and for the first time, we have science and assessment tools that support our clinical judgment. Measurement-based care tools are to be utilized to develop baselines and demonstrate objective gains in functioning. We've also begun to standardize language within an integrated system of care, developing metrics and utilizing data to determine our own program effectiveness, and we're making improvements in program-based practices based on those particular metrics. If you look at the bottom of this particular slide, there's a link to the Kennedy Forum that actually explores the whole concept of measurement-based care tools, and I suggest that you review that document as well as the measurement-based care tools that are available to the particular demographics that you serve. So we talked about what are some of the agency benefits to this transition. Over the last year, we've visited over 12 to 15 sites who have been up and running for since being designated. And these are some of the observations that we got from both our program reviewers as well as through the agency's articulating the benefits. So enhanced staffing for the provision of integrated services has allowed for medication-assisted treatment to be provided in all elements of care. There's an increased utilization of beds in stabilization now that they provide ancillary withdrawal services. There's an increase in lengths of stay for those who have transitioned from 816 medically monitored from 2 to 3 day stays to 14 to 30 day stays. There's been an expansion of mental health services as reported through interviews with participants in treatment. Those long waits to see psychiatrists or other mental health professionals have been reduced to days rather than months. Most participants in treatment today that have transitioned report that their medical needs are being met. There's been an expansion of referral sources to include community stakeholders. So districts are very interested in 820 as it reduces hospital stays. PPSs are partnering with our transition Part 820 providers. Managed care organizations, it's a win-win situation for them, and they are extremely interested in the implementation of 820 services throughout the entire state, as well as BHCCs have shown a tremendous interest in this transitions. Clinicians have reported to us that there seems to be a decrease in resistance when you become more patient-centered. There's a decrease in resistance and higher retention rates in treatment when individuals are engaged and allowed choice. There's an increase in communication between transdisciplinary teams. So part of that transition to Part 820 has broken down a lot of the silos that have historically existed within programs, wherein there were separations between mental health staff, medical staff, and SUD staff. The transdisciplinary teams actually have created weekly or, for that matter, daily transdisciplinary case conferences. There's ability to provide in-house evidence-based interventions. Feedback from providers has been that their experience with MCOs has been positive surrounding authorization and utilization reviews. As said earlier, the MCOs find value in referring participants to stabilization and rehabilitation as it provides them cost savings. Reimbursement has had its initial hiccups as both parties struggled with new claiming systems. But after an initial period of time wherein they were able to reconfigure their billing systems, they're now receiving reimbursement. One provider commented that we provide services, not a program. And since we've made that shift, we seem to be attracting more staff, and the staff that are providing strength-based trauma-informed services have better morale. Clinical staff report with new medical and mental health staff, they can focus on working with participants on their issues rather than spending hours giving out medications. I had said that the managed care organizations found value in this, and they also liked the objective measurement of outcomes. Participants' benefits to transition. We looked at client satisfaction surveys in the providers that had made the have made the transition, and providers' internal satisfaction surveys reveal shorter wait times to access services, right? As a result of doing intakes 7 days a week, people are actually being able to access the services that they require. Residents spoke about access to medication-assisted treatment with less stigma from staff. They were medically triaged within 24 hours of admission. For residents with co-occurring conditions, their mental health needs are being attended to upon admission. Traditionally, as I had said earlier, they would have to wait 4 to 6 weeks for appointments with community mental health providers. Engagement and support that's trauma-informed and strength-based, as well as recovery wellness supports that provided them choice, and they spoke about being linked to recovery peer coaches and advocates that actually ensured linkage to community services. So there's a big win there as well. So what's needed to make all of these transitions to 820? And so we talk about an ability to conceptualize that each element is freestanding, right? There are both clinical implications to this transition as well as administrative implications that require your consideration before applying for Part 820. We actually developed, in collaboration with providers, a self-assessment tool, and there's a link to that particular residential readiness guide, right? So the self-assessment process should be utilized by a transdisciplinary team as it's divided into various topic areas from demographic to staffing to financial planning and contracting, of which will require different skill sets. So just going into your office and writing up, answering the questions in the designation application, will not suffice when making this paradigm shift. You need to include all of those different disciplines as there are implications for each discipline within your agency. It's going to affect all of those different areas. So the first bullet talked to, having the ability to conceptualize an element as being freestanding, right? And what that actually means is that since movement through the elements of care is not linear, every individual that goes into stabilization is not moving directly into rehabilitation and subsequently moving directly into reintegration. This is a huge change in thinking that actually takes into account individuals' risks and resources. So some of our participants come to us with housing. Some of the participants come to us from jobs and subsequently may not need the services of all three elements, right? So what we're asking providers to do is develop a menu of services to meet the needs of the demographics of the population that you serve, to identify expected outcomes. For instance, in stabilization, a expected outcome would be a reduction of urges and cravings, a decrease of mental health symptoms, possibly a development of a housing plan. So we need to have an accurate, appropriate delineation of expected outcomes and outcome measures, as well as linkages to service providers in the community. And, as we're looking at this transition and trying to conceptualize the implementation, you've actually got to look at your physical plan. can the physical plant adequately contain the program? And what I mean by that is, you may have the capacity to do one element of care, right? Enough group rooms to facilitate group and services for one cohort, but if you decided to do all three elements, could the physical plant actually contain that? Is there enough space to do individual counseling as opposed to housing? We visited a provider that had a counseling corral, which was an area where counselors could work. There were 12 counselors in booths. It met the need to write group notes, but it didn't provide for the confidentiality needed to do one-on-one counseling. So again, I think that all of those different areas need to be explored prior to developing your designation application, and specifically to looking towards the implementation of those services when designated. So we're going to kind of define the individual elements. Stabilization requires the supervision of a physician and clinical monitoring to address mild to moderate withdrawals, severe cravings, psychiatric and medical symptoms. And this is really key, right? That it also speaks to the need for those individuals that need to be stabilized for their emotional conflicts. So historically, our providers have attempted to provide stabilization services for years, yet those services were not appropriately staffed to accomplish that task. Our task has been to develop strategies to direct individuals to a stabilization element as opposed to detox. This then fills a much-needed gap for support of individuals who have mild to moderate withdrawal symptoms, severe cravings, and, as stated before, emotional conflicts. OASIS has negotiated with managed care organizations to allow admission to stabilization individuals without prior authorization for up to 14 days. You do have to inform the MCOs within 48 hours that an individual from their plan has been admitted, transfer an identified locator, as well as fill out an Appendix A to begin the filing of that claim. Stabilization can be used to address chronic and psychiatric needs of the population. We're conceptualizing this element of care. Your design should include groups and services that are holistic. So this is not a hospital detox. If you're conceptualizing it in that fashion, that you need 24-hour monitoring and medical staff, then the person would actually require, a higher level of care. Subsequently, although person-centered, the tasks to be accomplished cannot be met in 3 to 7 days. So again, this is a shift, right? We had historically had 816s that kept people for 3 to 7 days and were linking people to services. In this element of care, your goal is to actually provide a breadth of services. Rehabilitation element is designed for individuals with significant functional impairment. The key for this population, we believe, is ensuring that appropriate assessment is performed, that individuals are matched to services that can meet their unique needs. So what we've seen with very successful providers is that they developed a menu of services. They provided choice from evidence-based groups. They set up baselines using measurement-based care tools, and they also linked people to recovery wellness services. Functional impairment within this population should be considered through utilization management as programs attempt to intervene with individuals' maladaptive survival strategies. These strategies have been developed or adopted over a course of the participant's life and subsequently can't easily be altered within days or weeks of admission. And I have to tell you that our successful providers who have identified those evidence-based groups and have been able to articulate the services that they're providing were very much supported by the managed care plans. Developing the ability to articulate the myriad of services provided is essential to your communication with MCOs. So, as I had articulated earlier, that the key to success in implementation of 820 is the ability to both collaborate and communicate all of the services that you provide, right? So, you guys are doing an excellent job of the minute someone comes into residential care, you're doing great work stabilizing many medical conditions that you've never taken credit for. By virtue of having a safe, sober place to sleep in, you add a nutritional diet, you've reduced people's high blood pressure. We've never taken the credit for that, nor articulated it in the notes that we write. So this is an opportunity to do that. Reintegration. Reintegration in both congregate and scattered sites will provide linkage to Part 820 to outpatient services. There are opportunities to actualize skills learned in treatment in the community. It gives you an opportunity to look at community services and resources, services for those transitioning to long-term recovery and independent living. So to be clear, many of the providers who have transitioned to 820 reintegration have provided linkage to community services for years. But what we're asking you to do is look at the new recovery centers, that are available in your community. Look at the local gyms, yoga, meditation, and other wellness services that your demographic population could benefit from. Key to this element are logistics involved in providing services for individuals as close to their communities of origin. Key to this is ensuring participants' transitions to stable housing and employment, and that's where you can partner with the 822s who have recovery coaches now. Many of our 822s, are presently staffed with recovery coaches and should be utilized to ensure that those are warm handoffs. Part 820 certification. So just to clarify, providers will have the ability to apply for one or more of the service elements just described to you. Consideration should be given what the workflow would look like, what movement through the elements of care will look like within your program, and how it will impact access. So what I'm talking about is if you decided to do all three elements, right, would that impact access into stabilization if you were actually providing the element of reintegration where people had longer stays. We're not discouraging or encouraging. We're just kind of saying to you that those are considerations that one needs to look at when identifying the elements of care that they would provide, as well as what the workflow would look like. Bed distribution will be determined by participant need. So unique to 820 is that you don't have to designate a certain number of beds for stabilization, a certain number of beds for rehabilitation. Our intent is to allow for flexibility, and bed designation will be fluid based on participant demand, right? Yeah. So at a certain time, you may need more stabilization beds and less rehabilitation beds, and at other times, those beds that were formerly bedded by individuals in stabilization have now transitioned into the next element of care. So if you have a 50-bed facility, as I said, you don't have to specifically assign 25 beds to stabilization and 25 beds to rehabilitation. As it pertains to specific staffing structure, stabilization and rehabilitation have new requirements, right? There's a specific staffing structure that's required for those two elements of care. Now let me reintegrate because there was a lot of confusion. In reintegration, there is no specific staffing structure outside of what presently exists in an 819.10. Let me say that again. There is no specific staffing structure outside of what presently exists right now that you're doing. Treatment approaches, are specific to the element of care. There's a provision of specific services, policies, and procedures in accordance with 820 regs. Should be updated to reflect your present regulations should be attached to the designation application and should be updated to reflect 820 regs 1 through 17. When you are designated, right, your approved designation will be reflected on your operating certificate. So if you've applied for 2 elements of care, that will be reflected. If you've applied for 1 element of care, that will be reflected on your designation application. So before I go into the section 2 in which we identify all the different operational guidance documents, I want to speak to the many success stories that we've witnessed in the implementation of patient-centered, trauma-informed, strength-based services. I'd like to, say that anyone that, has begun this process, kudos to our early adopters. We understand what a huge paradigm shift in services this is. There's a lot of philosophical transitions that we're making from treatment approaches that you should be applauded for. The expectation is that people move towards the implementation in the services in a very calculated way, and subsequently we've tried to provide the support through the following documentation. If you take a look at this first designation application webinar, if you actually go to the MCTAC, CTAC New York website, there's actually a webinar that will walk you through question by question as to, what the responses should look like specific to the element of care, specific to the population that you deserve, that you serve. On this particular slide, there are several links. The Oasis Residential Redesign Conversion application can be linked through this particular hyperlink. There's a Residential Redesign Personal Qualification Sheet. Again, that's linked through this hyperlink. There's guidance in the development of Part 820 policies and procedures. There's also support. So for those of you that are in this application process and have been looking to provide us with a perfect application, there is no such thing, because all we're doing is walking you through your particular clinical vision, your particular fiscal vision of how you would make this transition. So there is definitely support once you send your application in. There is both an individual that is reviewing your narrative and will support you through that process, as well as an individual that is supporting you through the process of the development of policies and procedures. There is a Part 820 transition planning checklist that actually was developed with the support of our most successful providers, identified, the training needs that were required to make the transition, the process in which they walked through step by step all the different implications of this transition and how were they successfully addressed. In reference to policies and procedures, there's actually a checklist that's provided, as well as the original webinar that I spoke about on the previous slide has our program review unit go through what they're actually looking for in those particular policies and procedures. You should be aware that there are new PAS forms that were developed as a result of Part 820 and took into consideration comments surrounding admission and discharge that providers had been giving us for years. So there's actually a transition from one element of care to another when it's done internally within the same agency, so you don't have to admit and discharge individuals receiving services within the same agency. There's also a separate transfer document, again, when you're transferring individuals from one PRU to another. So so this was an attempt to reduce paperwork and workload that we've been hearing from our providers that has been daunting. There's a webinar surrounding that, and again, there is that link to measurement-based care tools that was provided by the Kennedy Forum that explores the entire concept of developing baselines and using objective measures rather than subjective measures in articulating the services that we provide. There's also, on this particular slide, we're talking about clinical components and other resources. There's a clinical pathway document that was developed for residential redesign that will be very helpful in assisting you to vision the services in each element of care and what the clinical pathway would look like individuals entering stabilization versus the services and the pathway would look like for someone going into rehabilitation. That's an excellent resource to be utilized in conceptualizing the interventions and services that you provide in each element of care, and also would provide you a script to begin conversation surrounding utilization review as to what milestones were met and what further work the individual in treatment needs before they can be discharged. There's also an OASIS Part 820 Nurses FAQ, which clearly identifies that these stabilization services are not a hospital setting. You know, they will not have their own pharmacy. There is no dispensing of medication. Those were large concerns that had to be clarified, and that particular document will assist you in clarification of nurses' roles within Part 820. There is also links to the level of care determination, which is part of the documentation that will be needed to provide it to managed care organizations in order to put your claims in. So we've covered a lot of different information here thus far. I'm going to hand off to Ileana Meltzer. And Ileana?
Sure. Hi, everyone. This is Ileana Meltzer. So the purpose of today's webinar was twofold. It was to address those programs that are going to be newly submitting 820 designation applications. It was to let that group remind them about myriad resources that are available to guide them through the application process. So in particular, the last two slides that Henry went through are extremely valuable resources for programs to familiarize themselves with each of the documents that are available through the different links. And the reason why we bring that, we wanted to talk about that a little bit, is some of the lift for how to think about getting ready to do your 820 program had been done by some of the early adopters. And the links out to the Chapter 1 Administrative Readiness on this slide and Chapter 2 Clinical Readiness are links to conversations done by two of our early adopter programs. And it's their direct experience about how they thought about getting ready to not only do the 820 application, but once they go live, how they were going to support that implementation from an operational perspective. And what they did was they took a lot of the materials that OASIS had already created and also informed us of ones that we needed to create. So I really encourage folks that have not yet submitted the application to take a look at both of these providers talking about how they thought about it from both an administrative perspective and a clinical perspective. And it's important as programs are starting to do the initial work about thinking about which of the elements they want to submit an application for, that they bring together both the clinical and the administrative staff to have a dedicated conversation about not only the clinical vision of what the program wants to do, but from an administrative perspective, how they would support that. And administratively, that includes things like how documentation is worked, how communication is going to happen between the clinical and billing staff to support conversations with the plans, how claim submission is actually going to work, how scheduling is going to work. all of those things become critical to having successful operation past go live. And what we've seen is those providers that really have a robust conversation about both those aspects as they put together their application using the previously identified resources tend to have a higher level of success with the actual go live than programs who really didn't bring together both aspects of clinical administrative. Next slide, please. So this next slide is just to refresh people's memories about what revenue sources are available to the different 820 elements. And earlier on in today's presentation, you'll recall that some of this came from, some of the ability to do residential redesign came through the 1115 Medicaid managed care waiver. And what that did was that allowed us for the stabilization and the rehabilitation elements, in addition to the previously existing funding sources that you see listed here, which includes congregate care, food stamps, the block grant, OASAS net deficit funding, in addition to those pre-existing funding streams, which remain upon conversion to the 820 elements, the stabilization and the rehabilitation elements are also able to secure a per diem payment for the treatment services that are delivered in those two elements. That per diem payment runs through the Medicaid managed care companies. It is not a Medicaid fee-for-service reimbursement stream. So that's where the plans not only become our partners from a clinical perspective as far as supporting the 820 program and supporting individuals once they leave 820s, but they're also our partners as far as bringing additional revenue stream to the stabilization and the rehabilitation elements. Finally, at the bottom of that row, you'll see that there is, OASAS has what we're calling startup funds that are available to the stabilization and rehabilitation elements. There is included in this webinar, there is a one-page document which describes what that funding is available for and the process for going ahead to get that. So again, before we leave this slide, what we wanted to do was remind people that the pre-existing revenue streams, congregate care, food stamps, block grant, net deficit, those pre-existing funding streams remain. The per diem reimbursement for stabilization and rehabilitation is additive to. And additionally, there's the startup funds that are available for stabilization and rehabilitation. I did see that there was one question that came through asking about if the per diem is available for the reintegration. At this juncture, it is not. That is a function of conversations that would need to happen going forward within the context of Medicaid managed care implementation. So I did just want to acknowledge that. Next slide, please. So we talked a little bit about, and I wanted to pause here because initially there was conversations about where the per diem reimbursement would come from. So as we've talked about, it comes through the Medicaid managed care plans. So programs, and this is key to as you're thinking about your readiness and getting ready to go live with your 820 programs if you're doing stabilization and rehabilitation. Key to that is reaching out to your area managed care organizations, introducing yourself as a up-and-coming Part 822 program, and getting a warm contact with whomever is their provider representative to help navigate the program through two key things that are very important to being able to secure that per diem. Programs must be configured in a plan's claiming and contracting structure in order to submit that per diem to the plan. Without that technical support, without that administrative aspect being put in place, programs aren't able to submit those claims to the managed care companies. So the lift on the beginning is two things. You want to have conversations with the plans. Again, you're going to see that theme of always knitting together both administrative and clinical conversations. So in talking with the plans, it's the clinical aspect of this is what we're doing, this is our vision, this is how we can work with you and our members, and then you have conversations about how to configure yourself within the plan's contract structure and within their billing structure. What you have here is a link to who you can reach out to at the individual plans to start those conversations. Additionally, OASAS every month sends a roster to the plan trade organizations that contains who is operational currently as an 820, as well as those that are in the process. So the plans themselves have a bit of a warm handoff knowing what is the full complement of the 820 providers that are available throughout the state. Just to reiterate, programs should not be submitting claims to Medicaid fee-for-service. I think we've talked about that enough. It runs through the plans. It requires a contract. You've got to be configured. Some of our programs have chosen to take the responsibility for doing direct claims and submissions themselves. Others have chosen to work with vendors. That's at the discretion of the program. Either works. But one of the things that you're going to see, going back to that slide that had the resources available, is in that checklist, talk with your plans about the ability to do any sort of claims testing prior to go live so you can triage what, if any, are individual data elements that might be jamming up your ability to submit claims. Okay, next slide, please. So staying on the theme of claim submission and what you need to actually do claim submission, these are also key documents that I strongly encourage both the administrative and the clinical leadership to be aware of. And what this talks about is the rate codes, the modifier codes, the CPT codes, et cetera, that are needed to populate an 820 claim in order for it to be accepted by the plans. It's important to recognize that where the state was able to standardize data elements on those claims, we have. That includes, but is not limited to, the rate codes that are assigned to the different stabilization elements, the modifiers that are assigned to those, as well as the HCPCS, PICS, and CPT codes. Where there's variability among the plans, you'll see that we have required plans to provide that information to providers. I'll pause here to acknowledge that there are some instances where programs have gone live, and after go-live date, they've had specific issues with claim submission. In those instances, there are a couple different tracks that providers can pursue that include both reaching out to OASAS regional office to signal the initial conversation, and where it's appropriate, we can elevate it as a complaint to the Department of Health. So there is opportunity for assistance in the event that claim submission becomes an issue after go live, but what we've discovered is the programs that in advance of go live work with their vendors or work in-house to sit directly with the plan representative and do the claims test process. There's a lot less of that issue. Next slide, please. So this piece, we're now on the slide titled Expedited Medicaid Managed Care Enrollment. All the reimbursement for stabilization and rehabilitation, that treatment per diem, runs through the Medicaid managed care plans. There has been a customary length of time that was built into the overall New York State plan enrollment system about how long it took somebody to get enrolled in and assigned to a Medicaid managed care plan. What we heard from some of those early adopters was the length of time that was associated with putting someone into a Medicaid managed care plan was causing issues as far as being able to secure that reimbursement for the treatment per diem and work with the Medicaid managed care plans. So what OASAS, in cooperation with the New York State Department of Health, was able to do was put into place what we're calling an expedited Medicaid managed care enrollment process. So again, as programs are getting ready to understand what's needed to be in place about go live, it's important to understand that for those individuals that come to you with a pre-existing Medicaid number, this is not about expediting the actual review to become Medicaid eligible to begin with. This is about getting someone enrolled in a plan. So what this process does is if you have an individual who's not yet enrolled in a Medicaid managed care plan, it decreases the amount of time it takes to get that individual enrolled in a plan and responds to some of that initial concern that we got from the field. So this is another key piece of information, understanding of process, that as you think about the administrative aspects of getting ready for 820, you're going to want to make sure you have entities, staff, however you're set up, that are fluent on how this expedited process works, who it applies to, and the pieces of information that will be needed when the plan reaches out through the designated phone numbers to start to do plan enrollment. Next slide, please. So another part of getting ready for 820 is understanding revenue streams. And a few slides back, you saw that there were a variety of revenue streams that were available to those programs that are becoming Part 820 programs. In addition to the previously available funding streams that we already talked about, on the stabilization and rehabilitation side, there is the treatment per diem. What we learned from some of those early adopters is if they went through and did the calculator, it helped them get a sense of what future revenues may look like. And a couple different ways they did it. We had one provider who said they looked at who they were currently serving and thought about, would that person benefit from the stabilization element? Would that person benefit from the rehabilitation element? Would they benefit from both? So they started getting a sense of what their patients currently looked like, and that helped them give a sense of which per diem price they would be working their way into. It also gave them, and this is where you start to see the ability to knit together the administrative thought with the clinical thought, it also gave them the ability to really think about the fact that, in particular for those groups that decided to do stabilization and rehabilitation, it emphasized the fact that transitioning through the different elements really is patient-centered. So it gave them another pause point to think about clinically, how would their program operate to allow someone to access stabilization and or rehabilitation as needed for that particular individual. One of the questions we frequently get from programs is, I'm not used to working with Medicaid managed care companies, so what's a good rate of claims payment that I could use as a starter place for doing my revenue calculator? So we encourage people to use like a 55% mark, not a prescriptive percentage, but it's a good starting point. You don't want to overstate your anticipated revenues, nor do you want to understate them. So the 55% builds in that some of your folks are going to be coming right in with managed care. There are some programs that are going to have an easier time with contracting or not. So that's just a good starting spot. The next thing is, this is that link that I talked about earlier where there is the ability to secure $205,000 startup funds for the stabilization and the rehabilitation elements. I would encourage people to take a look at that particular document and understand that in order to secure the $205,000, you do need to have a New York State Medicaid provider ID number in place. So for those programs that have no Medicaid provider ID number in place at all and are thinking that they may want to do the stabilization or rehabilitation element, again, this is a piece that you would want to put into your pre-readiness planning process so you're up and able to do the process to get the $205,000. Finally, well, actually not finally, there's two more pieces on here. This last piece is when we transitioned from 819 to 820, there was a request to affirm that the 820 programs, just like the 819 programs, were eligible for congregate care level 2 funds. So most of this has settled. We worked really hard with the local social service departments, but every now and then you'll get, say, a staff member who's new and they're not sure. This is your go-to document to affirm that the 820 level of care is eligible for congregate care level 2 funds. And finally, this last piece is, you'll recall a few steps ago, I was talking about programs need a Medicaid ID number, not only to secure the $205,000 startup funds, but in some instances is a data element that the plans need in order to facilitate claim submission. So if you're an entity that has never been involved in Medicaid billing, you're going to want to familiarize yourself with the 820 Medicaid application so you're able to get a Medicaid ID number, not for the purposes of billing New York State Medicaid fee-for-service, but for the purposes of securing the 205 startup funds and working with your plans to get configured in their systems. So, big picture, what we wanted to do today was remind everybody who has not yet submitted an 820 application about the plethora of resource documents that are available to support people and programs as they start to think about transitioning into the 820 elements. We wanted to make sure that we messaged that there's both the clinical conversation and the administrative conversation that really needs to be had prior to the go-live date. You want to really have your staff talking about both aspects of how to operationalize your 820 program, so when you do go live, you minimize some of the implementation efforts. We acknowledge that there are some programs that even after go live still had issues. Again, we work with our regional office, we work with the New York State Department of Health, and where appropriate, we work directly with the plans to sort of facilitate correcting some of those conversations. And at this juncture, what we're going to do is we've gotten some questions in from programs, so we're going to mute ourselves for a moment while we go through those questions and take.
Great. So while Ileana and Henry review the questions that have come in, I wanted to thank them both for running through all this content and really important material, and encourage you, if you haven't already, to submit your questions via the chat box functionality. So that's, again, if you're looking at your screen, it should be found on the right-hand side of your screen towards the bottom of the right-hand side. So if you want to take a moment and chat in your questions, we've gotten quite a few so far, so Ileana and Henry are kind of reviewing them before they start to answer. So we just want to encourage you, if there's any other questions, to keep them coming on in. So we'll be back shortly to get started with answering. And again, if you're on the line, thank you again for joining us today. We are just taking a moment to pause and review all the questions that have come in. So thanks for those who have submitted. If you have more questions, please keep them coming on in. And just as a reminder to everyone that we are recording this webinar, and the recording of this webinar along with the slides are going to be posted on the MCTAC website, which can be found at ctacny.org. It will be posted most likely by close of business on Monday. So stay with us another minute or two while we review, and we'll be back to start answering. We want to thank all of you who are sending in more questions. We appreciate that. We are just reviewing them again. So if you're on the line and wondering if everyone was muted, we're just taking a moment to review the questions before we come back and answer them. So bear with us another minute or two, and we'll be back to answer those questions.
Okay, we're back on. So we had a question that surrounded, what were the differences between detox and stabilization? And that's really, between hospitalized detox or medically supervised detox and stabilization. So stabilization services are identified for individuals with mild to moderate withdrawals. There was a question as to what the cutoff would be surrounding CWAS and COWS scores, and that's really a question that would have to be answered by the medical director of your facility, because what's unique to 820 is rather than OASIS identifying admission criteria, your medical director is overseeing the entire process and subsequently will be developing his own ancillary withdrawal protocols that will be reviewed by the OASIS medical director. Okay, so that has to do with stabilization versus detox services, what the cutoffs are, and as identified, your own medical director will set the criteria. With the caveat that we are looking for mild to moderate withdrawal that does not require 24-hour medical supervision. Does reintegration require a voc ed counselor? No, it does not. It requires linkage to employment support services within the community, and that can happen directly through the 822 that you're working through, or a separate linkage agreement with a community provider.
Hi, and then we did receive a couple questions and one point of reminding from one of the programs, so I wanted to thank you for that. The 205 is available for programs that are converting from an 819 to an 820, not an entirely new provider that is not known to the OASIS system. One of the programs asked us to remind those folks on the call that while you're in the process of finalizing your contract and your configuration with the plans, you can do single case agreements to facilitate getting payment for that particular individual. So whoever tapped that out, thank you, great tap out. And then there was also a question regarding OASIS review of 820s going forward and what that process would look like.
So in regards to 820 reviews, those will happen probably a year after you go live. We are piloting an instrument right now for that particular review, and that particular instrument is being piloted and is provided to the individual provider prior to the program review going out. Possibly in the near future, it'll be posted after further internal review.
And so at this juncture, there were a couple other questions coming in that we're going to need to circle back on. In particular, there's the one related to Medicare coverage. I think I know the answer to that one, and it should be in the FIDA contract, but I want to double check that with legal counsel. So at this juncture, Meg, I think we are good to close. We'll follow up with the FAQ document for those questions that we weren't able to get to. So do you just want to talk a little bit about when the recording and the slides would be available?
Absolutely. Thanks, Ileana. So as you said, we've been recording the whole webinar today, which is fantastic. So we'll be able to post it with the slides that accompany on the MCTAC website shortly. So we said Monday. They might actually be up as early as Thursday evening. This all is dependent upon how long it takes WebEx to kind of process the recording. So if you would like to start checking the MCTAC website as of tomorrow evening, fantastic. But if at the latest, we'll get this all up and posted on the MCTAC website by Monday. And if you have any questions about where it can be located, where this recording is going to be located, you can always email mctac.info@nyu.edu, and we'll be happy to guide you to the location of the recording and the slides. But I think with that, Ileana, if it's okay with you, I might end the webinar and just thank everyone for joining us, unless you have any parting words.
Yes, no, great. Thank you so much for everything, and we hope people found this useful.
Thanks again. Do your work early. Don't wait until the lights go on before you start to attempt to implement, these different services that you're identifying in your application. So early adopters took a while to train their staff. Thanks again.
Thank you.